the severe acute respiratory syndrome coronavirus type 2 or SARS-CoV-2 is a virus that's definitely spread through our breath. Whether we consider it strictly a droplet type of transmission or an airborne transmission, really the truth is probably a little bit of both. And it depends a little bit on context, where transmission events are occurring, for example. So this virus absolutely primarily spreads from one person to another through our breath, and largely does so in relatively large respiratory water droplets. But the size of the droplets that come out of us when we breathe are really on a continuum, and it's not just like, oh, at this size cutoff, there's no virus present. What we're finding is that as groups are more crowded in poorly ventilated indoor areas, that the SARS-CoV-2 virus travels farther than 6 feet and can behave much more like an aerosol than strictly a droplet dispersal virus. In areas where there's good ventilation, for example, outdoors, or in hospital settings where ventilation has been specifically engineered to move more air and filter air, then the virus behaves much more like a droplet type of spread. And that's probably why for SARS-CoV-2, we don't see, for example, the household transmission rate that we see for more commonly aerosol pathogens or airborne pathogens like tuberculosis or measles or chickenpox virus, for example. And probably also helps to explain why what we call the R0, the average number of people who get infected from an infected person, is much lower than those other diseases like TB or measles or the varicella chickenpox virus. So it's not correct to say strictly this is just a droplet spread organism. It in certain circumstances likely is spread through respiratory droplets that are small and qualify as airborne or aerosol spread. But what this really means in practical terms is that we need to avoid closely crowded indoor settings, particularly when people are not wearing masks and the indoor areas are poorly ventilated. On the other hand, ways that we can protect ourselves from this virus are the same as they have been yesterday compared to today, which is creating social distance. Universal masking remains really important and is effective, and paying good close attention to hand hygiene to limit the risk that we inoculate ourselves with the virus. At this point, I don't think we need to reimagine what we're doing to prevent the spread of infection. We need to double down on the things that we know work. For example, limiting the density of people in closed spaces, particularly those that are poorly ventilated. It would be great if we could fix the ventilation on all of our buildings. That's going to probably be a longer term fix than something we can do in the short term. Certainly ongoing epidemiological evidence where we can see outbreaks, we can measure or estimate the R0, for example. We could, of course, do more sophisticated studies looking for infectious virus in enclosed spaces. But a lot of this is just good, solid public health epidemiology and clinical infectious diseases. We're learning a lot about the effectiveness of PPE, for example, and we're going to be able to draw conclusions from the prevalence and incidence of transmission in hospital settings where we're using PPE like surgical masks and face shields rather than in some settings N95 respirators or PAPR devices. And so I think just over time we'll get a sharper view and probably continually to get a more nuanced view of exactly when and how the SARS-CoV-2 virus spreads.